Hello and welcome everyone for this live webinar. Today, actually, it is a hybrid webinar by GSI in association with the Coimbatore Society of Ophthalmic Surgeons. We welcome you all, and this is Dr. Satyan for you here. Today, we have 15 minutes of keynote address, and then we have the very awaited quiz program. All of you can actively participate and win prizes. So I'll just go to the topic. Today's topic is on the diagnostics demystified. Let's see how we can really use this with yeah. I think some of you have seen the previous programs, and we have 3 more programs to go in this week. And we have the quiz program after my talk is over. So the goal of glaucoma management is to maintain a reasonable quality of vision with a sustainable cost. So that is going to be the key factors, because it is not that you charge too much and then ask the patient to come back for often reviews, all those things. So whenever you have a structural damage, always you have the functional damage in the glaucoma that can be detected by doing a different type of investigations. You can see that here. And then we have reasonably good enough number of tools, the investigative modalities, both where we can do the structural damage assessment by subjective as well as by objective methods, and also the functional capacity can be seen both by subjective and the objective methods. When you have a retinal ganglion cell loss, it is not necessary that one may have only a glaucomatous optic neuropathy. It may be because of the traumatic optic neuropathy, neurodegenerative disorders, vascular disorders, or other toxic optic neuropathy. So the importance is to understand what is the structural damage and what is the functional loss. It may help us to understand the severity of the disease. So it helps us in grading of the disease. And also we can look at the progression of the disease, and more so, what is the actual disease? Is it only glaucoma? Is there any other associated diseases along with that? We can look at that. So the simple method is the fundus examination. All of us know how to do the fundus examination by direct or indirect ophthalmoscopy, but commonly used is our slit lamp examination. So what you see is a small disc area. Depending upon your slit lamp and the magnification, you can see how the disc of the size of the disc and various characters. And you move to the vessels and you move to the macular area. But this is a small zone which you really capture, and your occipital cortex has to process that in a very quick time, and it has to compare with between the eyes also. But when you have the fundus photograph, you can see how big is your image size, and in comparison to this is so beautiful, right? We can really pick it up. You have like 30 degrees, 45 degrees, or 60 degrees, or 90 degrees, or even it goes up to 110 and 200 degrees of viewing angle. So more the viewing angle and bilateral comparison, then you have a better understanding about what actually is going on with your optic nerve and the surrounding areas. You can increase, zoom it like, 200 times you can zoom it. And these are the SLO-based images. You can, every nerve fiber layer, you can pick it up and see what exactly is going on. In comparison to the hard copy, again, you put in a plastic sheet. Whenever you just see that and then try to open that sheet, what happens is the color gets stuck to that sheet. So over a period of time, the color changes, but whenever you have the digital soft copies, then your image quality is much better. Again, you can see all those, what is it you really require to see. In the clinic, what you really need to do is you just connect your machine through your LAN connection, and you can connect it to your desktop, and you can really see the digital copies, soft copies so clearly and identify. You can really look at the disk size, varied disk sizes, small to large, and then you can look at the disk shapes and understand, is it a glaucoma or non-glaucomatous in origin. You can look at the pattern of the retinal nerve fiber line. Is it really a POAG pattern? Or you see here, which is much more closer to the papillomacular bundle to show that it is more of an NTG pattern. Then, of course, you have the disc hemorrhages, which tells you something. Is it a glaucomatous disc, or is it a normal tension glaucoma disc, or how much it is recurrent? So once you have the photograph, you can see the recurrence. You can see the absorption, you can see the damage, what is happening over there. So looking at the next area is the IOP measurement tool. Of course, all of us do have our NCT and other tools today, but the gold standard for glaucoma practice is always going to be only the regular GAT, that is appellation tonometry. Looking at the diurnal variation test, I'll just go through the test which is available so that you can understand better things. Ideally speaking, always we have to do a diurnal variation to understand how much is the IOPs at various time points in a day for the patient. Some patients will have a morning spikes, some have afternoon spikes, but most of them will have a drop in the IOP in the evening hours. So you may have misunderstanding about the patient, that patient, the IOP is lower, so the patient may not be having glaucoma, especially when you are seeing the glaucoma suspects. So this gives us an idea when it is spiking, when it is dropping. So based on this, we can change your way that you treat. Next thing is water drinking test. Is it really useful for us in today's practice? So there are various reasons how the IOP gets elevated in a water drinking test. We are not going to the depth of it. I'm just going to show you some of the examples. When you have a glaucoma suspect, when you have the water drinking test, it may not really show much of a change. Then you have a patient who has undergone surgery. You can see in the right eye, even after water drinking test, the IOP may not go up much. But you see the left eye, which is not undergone surgery, you can see there is a significant change in the IOP spikes. And similarly, when there is a failure happening in the operated eye, again, you can see there is a spike happening, of course, in the other eye as well. Looking at the pachymetry, there's a lot of misunderstanding again on the pachymetry and how you really calculate on the IOP levels. I'll just give you an example. IOP of 23 with a corneal thickness of 600. Many people tend to, what they do is you tend to reduce the IOP from 23, calculate that 50 or 60 thickness, and then say that it is only 19, the patient is not having glaucoma. It is not so. The patient's IOP is still high, probably it is an arterial hypertension, but the risk of developing into the next stage or the progression to either early POAG is lesser than those patients who are having a normal corneal thickness values or the lower corneal thickness values. Please understand these basics. Many people, what we have seen is like it is an established glaucoma. You try to look at the CCT values and then you're trying to treat the patient based on that. Don't do that. This helps in understanding about whether to treat in some patients or not to treat in some patients. That is all the CCT helps you. Looking at the gonioscopy, on this World Glaucoma Awareness Week, we really stress the need that every one of you have to buy a gonioscope and then make sure that you use the gonioscopy in all your glaucoma patients at least. So there are different type of gonioscopes. Single mirror is always my preferred choice with the coupling solution, which give you a beautiful view than any other lens, whatever I have used so far. And more so with the trabeculoplasty lens, which is one of the most beautiful lenses if you really want to do the recording, and then you can see that later also. That's one of the most beautiful lenses you can see. Always try to identify the corneal wedge whenever you are seeing the gonioscopy, because you may identify the pigmented small baseline as a trabecular meshwork and think that it is going to be an open-angle glaucoma, which is not the truth. And some people do the SLT on the pigmented small baseline, and then you may not get any result. So identifying the corneal wedge in a gonioscopy is extremely important. And this really helps to identify whether it is a pseudo-exfoliation glaucoma, or is it a pigmentary glaucoma, or is it there is an angle neovascularization is there. So this is one of my patient from Erode. So identifying this very small blood in the inferior angle, we found out that the patient had a carcinoma cervix. So it can help you out in many ways what the patient is going to. It is not only the glaucoma which you're going to diagnose. There are many more things that you can diagnose by looking at the gonioscopy. Of course, post-trabeculectomy, then you can see whether the ostium is patent or it is occluded, and many more things you can really look at using the gonioscopy. The post-injury, the angle recession glaucoma, how much is the widening there? Once you see the 360 degrees or angle recession is there, it is almost certain that it is just a matter of time when the patient is going to develop the glaucoma. Looking at the biometry, it's pretty useful, especially in angle closure disease. when you have the biometry values, especially on the aqueous depth, it is not the ACD, it is the aqueous depth that you have to look at. That means from the endothelium to the corneal epithelium, what is the depth that the patient has. If the depth is less than 2.48 millimeter, and if the the lens thickness is more than 4.5, then it is more significant. Also, along with that, you see what is the contour, the central contour. Is it a convex contour of the iris? So these three together helps you to identify whether you can go for a yard laser peripheral iridotomy in these patients or not. Looking at the visual fields, I'm a big fan of octopus. I'm not a promoter of the octopus. But then the octopus gives a lots and lots of additional values whenever you are doing it. It is a 9-on-1 chart, which helps us, especially when you see the grayscale of octopus. The grayscale of octopus is a real data. The grayscale of Humphreys is just, it is not the age-matched control data, but this is a age-matched controls. And then you can compare it when you have the digital device, you can just compare it in your desktop. And by binocular comparison, you can do it. So in one shot, you can see how the patient is doing. And also, I have not put the other slide that is called as a summation. We just click one button in the software, how the patient will have the realistic appearance of their field in one click of the button. So you can see the summation also. And the Babel's curve really helps us to understand how much is the general defect versus the localized defect in this. And the cluster analysis helps. If it is within the central 10 degrees cluster is affected, then we can really say that how aggressive that your treatment has to be for these patients. The polar analysis, basically it is not the true data, it is the extrapolated data of all the results. Then you can really see how much is the actual anatomical defect where it is going to be. Then you have the serial analysis, then you have the progression chart. The progression chart again gives you how much is the diffuse loss in comparison to the local defect. That again helps us to understand how we need to treat these patients. Looking at the OCT, I'll just go through very quickly. There are various newer understanding on the OCT, especially on the anatomy of the optic nerve head and also on the posterior pole. Looking at the anatomy of the optic nerve head, whatever we see in our clinical practice is the inner edge of the scleral ring is identified as the disc margin. But when you see with the OCT, that is completely different. You can see here, the red one is based on the Brooks membrane opening with the OCT based, and the green one is the disc margin by the clinically looking at our with our ophthalmoscopic examination. Both are two different things. But if you want to say which is the true disc margin, then it is going to be only the OCT-based disc margin, that is the BMM-based disc margin. So we need to have this basic understanding. This is how you can identify the Brooks membrane and the Brooks membrane opening. You can see the green arrows there. So I'll not again go to that in detail. Some of the OCTs gives you HRW, that is called as a horizontal rim width. The spectralis gives you the minimum rim width. The minimum rim width from the spectralis gives you a better idea of how much is the true damage happening in the retinal nerve fiber layer. So it has a much better comparison and the correlation along with the glaucomatous damage. Then you have something called as the posterior pole, where you really look at the retinal ganglion cell damage. So there is a specific pattern is followed in glaucomatous eyes. That means there is always a superior-inferior asymmetry. That is how you look at in the glaucomatous eyes. So you have all these softwares, you just access it in your desktop of your machine. So always we have to compare it with the structure and function. It is not that you identify something in isolation, you look at only the visual fields or look at the OCT and say the patient has a glaucomatous or non-glaucomatous damage. So these are some of the deviation maps. Some OCTs gives you the GCL with IPL, but we prefer to have only the GCL. The ICL, once it is combined, then you will have always some kind of an error. So these are all the deviation maps available. Looking at the glaucomatous damage, you can see the first picture shows normal. The second and third one shows the progressive damage in the glaucomatous eyes. And you can see in the last bottom picture, this is the vertical damage. And you can see there is a symmetrical damage. Once you have a vertical and symmetrical damage, that is mostly because the neurological disease not by the glaucomatous origin. then you have the overview. It can tell you each area. You can look at superior temporal and inferior temporal in the right eye, left eye of the MRW, and also the retinal nerve fiber layer, how the damage is happening over a period of time, we can really identify. The last one, just a couple of words about the ERG. There's a ERG called a diopsis ERG that is what we use in our practice. So you can see this sine wave pattern. Once there is a early damage is occurring, the ERG picks up how much is the cells are at stress. It will not pick up the dead cells. It picks up only the cells which are under stress. So that is what we are seeing here today. I mean, in this picture, you can see this is a machine. There's a different sizes and shapes of the machines are available. So ERG is helpful in ocular hypertensives or early glaucomas, where you can see how much the cells are under stress. So you can treat them a little bit more aggressively, where we can reverse the glaucomatous damage. That is the beauty of doing the ERG and identifying whether the patient has a damage. So this is in short or in nutshell, if I want to say, you do the fundus photography, OCT, visual fields, OCTA, all this helps, but you have to have this additional information like IOP, gonioscopy, biometry, and ERG and other risk factors like family screening, and then it gives you all that tests. So once you combine everything, if you can process that in your occipital cortex and you can come to some conclusion, that is how the patients, you can really help them out in treating the glaucomatous eyes. So thank you so much for this patient listening. And today we have a hybrid session. We have our president, CS Vice President, Dr. D. Chandrasekhar here. He is the master in quiz programs. I'm really happy to have the master with us today. And over to you, sir, to conduct the quiz program. I think I'm on time. Yeah.
Very good evening to all the friends online on Zoom and YouTube. Thank you very much for joining us. I'd like to thank GSI President Dr. Satyan to do a hybrid program along with the Coimbatore Society of Ophthalmic Surgeons. Very good evening. Just give a couple of minutes for us to set up the Kahoot. I'm sure all of you know Kahoot now. It's no longer new to anybody. You have to go to kahoot.it. Kahoot.it. There, this is the PIN number. I will tell you how to. This will be the PIN number. Once you put your PIN number, your nickname should be. We are going to have, yes. You're going to have two categories. You want to tell the prices, Dr. Satyan?
Yeah. The prices are going to be for both the PGs and fellows separately. You have 1, 2, 3 winners. And similarly for the consultants and the general practitioners, you too have the 1 to 3 prizes. So actively participate. I'm sure that you can really win the show. Dr. DC sir is asking for the amount. The prices are being given by Ajanta Pharma, but we'll announce that how much is the price amount in the once all of you win the show.
Yes. Thank you so much, Dr. Satyan. So you need to key in this number 235731. So you already were putting your names. Okay, we'll see the list later and take the top 3 PG fellows and top 3 practitioners.
We would also like to welcome our secretary, treasurer, and I can see them online. Thank you so much. And I am sure that we'll have a wonderful quiz program. Manish, you would like to say something? Most welcome to say something for our.
I'm eagerly looking forward to the quiz.
Thank you.
We have about 105 people. Some have come and gone. Actually, we have about 180 registrations for online and maybe another 80 people here. I don't know. All of you can join. It is not going to be hardcore questions. It is going to be enjoyable questions. And greetings to all the honorable office bearers of Glaucoma Society of India. We give another 2 minutes for everybody to join. You can.
അത് രണ്ടുമേ ഓക്കെ പോയിടും.
We can wait for another 2 minutes. Satyan? Some have some bad connections. About 10 of you have come and gone. Small announcement for those who are here. Some of you are fasting. In case you want to break your fast, the food is in the adjacent room. Hi, any messages from the webinar? Any of you here having problems? All okay? So we start off now. So all the best to all of you. So, okay, we have taken whatever names you have given. At the end of the quiz, we'll put the top 10 and take the top 3 from each category. And we have a couple of trial questions. This is the first trial question. No, 1 minute. So, literal meaning of glaucoma, match one of these things. And you have 30 seconds to answer. There are no marks for this. இதுதானே பண்ணிட்டு இருக்கேன். இது தெரியல. அது கீழே போச்சு இல்ல. அது இங்க இருக்கு பாரு. All of you online are able to see. So the literal meaning of this glaucoma is the appearance of the eye, which is supposed to be bluish green in color. So no marks for this. So 79 people out of the possible 150 got it right. Any of you online are having difficulty, kindly message before we go on. Another question is also a trial question. So at this point in time, fastest finger first. Dr. NB is been the fastest and then Lippy. So, but there's no marks for this and it will not count. The next question. What is this used for? This is used for what? Eighty, 90, 100 people have answered. You have another 17 seconds. Excellent. I'm sure all of you got it right. 145. Fantastic. Oh, 150 have answered this question. How many of you think you got it right? Okay, 72 said cyclodialysis. Goniopuncture, about 21 said. Goniotomy, only 42. Anybody here who would like to take the answer? What is that? Barkan's goniotomy. Actually, that is the correct answer. But I've given goniopuncture here. So who's wrong? Who's wrong? I am wrong. Quizmaster's decision is final. Though it's called the Barkan's goniotomy knife, this is just to tell, don't argue during the quiz. So this is just to show that it is Barkan's goniotomy only, not goniopuncture. So Quizmaster's decision will remain final. Okay. And team is not responsible for any connectivity issue. Where did you look for this finding? More of a fun quiz. Where would you look for this finding? Going on fine, otherwise we won't get 155. Loch Ness monster phenomenon in developmental glaucoma at the angle. 110 of you got it right. And the leaderboard would be Dr. AKS, Professor of Glaucoma anywhere. The next question. Which condition will show this? It's a very clear picture of what you will see. Happy to see consistently 150 people answering. You're happy? Thanks, Dr. Satyan. 156, almost 170 have logged in. So fantastic co-cell glaucoma candy stripe sign. The leaderboard continues. So here you have to remember, it is not the number of answers you get right. It is the fastest. I can get 3 answers right at the slowest time, but I can get 2 answers right at a faster time. I'll still be the leaderboard. So remember, fastest finger first. This sign is seen in which condition? double hump sign in plateau iris. That is the correct. 142 got it right. Okay. All big people are answering. Next question. What is this triad? Fifty consistent is fantastic. And I'm sure all of you got it right. This is the typical finding of three aspects: glaucom flecken, pupil and atrophic patches, acute congestive attack, Vogt triad. Okay. Next question is, where will you look for this? Which condition? Some of you are telling the answers loud. How can you share 100 rupees between 4 people then? Port wine strain in Sturge Weavers. All of you are experts of glaucoma. Many people to join you, sir. Dr. Satyan. Yeah. In which condition you get this gonio finding? Okay. You only. This kind of signing PAS you get in Sturge Weavers. Okay. Some new people are coming up. Simple. If you have seen this once, you will never forget. Iridoblast, post iridoblast. Very straightforward. If you have seen once, you will never forget. Arms tuberculosis. This is also a simple question. Cortexes. Associate with one of these findings. the 8-ball game in which the black ball is number 8, hyphema. Straightforward finding. Look at the eye and the hair. Lowest number of answers. Wardenberg syndrome, white forelock of hair and heterochromia. This is multiple answers. You tick all the correct answers and tick. Select and tick. Little tougher so that the order will change hopefully. So applanation, perimeter, Goldman perimetry, Goldman lens. Gonioscopy was a term coined by Trantas. Associate the chromosome for this condition. This is chromosons and the chromosome 10 is the correct answer. Everybody should get right now. The spherophakia, wheel Marchesani. What would you associate this procedure with? Oh, malignant glaucoma. Oh. Look at the clue and answer properly. Dear sir, நீங்க வரீங்களா? So, blood and tender retinopathy is nothing but CRO causing 100-day glaucoma. Oh, fantastic. Oh. What causes epidemic dropsy? Yesterday, today, tomorrow, all questions will be there. But everybody knows the answer. Argimon. What is the virus associated with Fuchs? My God. So fast. This rubella. Which condition you will get lens cornea touch? Likely. Peters anomaly. Not bad, over 100, got it right. So there you have a phone call from home. Can you go out and take? Friedenbold nomogram, with which of this you will associate, or everything? We discussed in the PG program, no? It's for shots. It will be there in the box itself. Shots tonometry. How much is the lens tilted in Zeiss 4 mirror? Not Goldman, Zeiss 4 mirror. Okay. It is 64. 59 is for Goldman. Another 3-4 questions. What is the applinating area of Goldman 80? What is the applinating area of Goldman applanation tournament? Okay, let us see how many of 156 got it right. The diameter is 3.06, but the applinating area is 7.35 millimeters square. What is the IOP difference between both the eyes? Around 4 millimeters or more. What do you call it? The same name for disc also, difference. Downey's sign. 2 more questions and we'll be done. What is this? It's not a printing error. These are white scotomas. Superb. 142 and The last question. Multiple answers are correct. Identify. So it's got nasal step and sickle-shaped extension of the blind spot. Seedles and Ronies. Should I put the leaderboard 5 or we'll calculate and put? Leaderboard I'll put. Calculation will come. So this will show the top 5 leaderboard, but the calculations will come later. Okay. But how will I identify the name? Okay. Okay. So these are the top 3 people. Congratulations. I do not know whether they're here or online. And there are 5 more. The list will come and it will be announced. And over to Dr. Thank you so much, GSI and Dr. Satyan, for this wonderful opportunity. Thank you all for coming and participating here and online. More than 170 registration, 100 were consistently doing online also. Thank you so much, Dr. Satyan. Over to you.
Thank you so much, Dr. Chandrasekhar sir, for this wonderful quiz program. And we will announce the results sooner, because we need to identify who is a PG and fellow, and then we need to identify who is the consultants and the general practitioners. So the first prize is going to be 10,000.
Each category.
Yes, in each category. And then second is 6,000 and the third is 4,000 rupees. So we'll be announcing that sooner, not probably today, because we need to see who are all the people. We'll announce it later. Thank you all for joining for today's live webinar and also the offline session here in Coimbatore. Thank you all. And we are just looking forward for active participation for the tomorrow's event by Dr. Pradeep Ramalu. There is an international speaker. So we're just looking forward to hear his talk tomorrow evening at 8 p.m. Thank you all. Good night.